Welcome to This Explainer. Today, we're taking a really deep dive to rethink everything traditional psychology taught us about two heavily misunderstood populations, refugees and people with disabilities. We're going to completely shift how we view mental health, exploring exactly why context matters more than ever. My goal today is to teach this in depth and help you truly remember these concepts. Let's jump right in. Here's our roadmap for today. We'll start by shifting the counseling lens, move through the complex refugee experience, rethink trauma and resilience, explore the social model of disability, look at stigma and autonomy, and finally, put context over pathology. Let's kick things off with part one, shifting the counseling lens. Historically, traditional counseling models were built around Western middle-class norms. Because of that, they tended to look at the individual in a total vacuum, just hyper-focusing on a person's symptoms. It's kind of like trying to figure out why a plant is wilting without ever checking the soil it's planted in. Multicultural counseling totally changes the game here. It insists we actually look at that soil, the social realities, the discrimination, and the structural barriers surrounding a person. It demands we recognize that human behavior, psychological distress, and how we cope are all deeply embedded in sociocultural contexts. If you remember one thing from this entire explainer, make it this: context is absolutely everything. Moving right along to part two, the complex refugee experience. To really grasp the psychological impact here, we have to recognize that the refugee experience isn't just a single, isolated event. It is a highly complex process of cumulative trauma. The distress almost always starts pre-migration. We're talking exposure to warfare, severe persecution, or profound loss. Then you have the migration phase itself, which often involves incredibly dangerous journeys, family separation, or years stuck in displacement camps. And the hardship doesn't magically vanish once they reach safety. The post-migration phase brings a whole new set of hurdles: severe cultural adjustment challenges, language barriers, poverty, and isolation. The trauma doesn't just stop when they cross a border. We're dealing with multiple, overlapping layers of adversity here. Because of these deeply layered traumas that extend way beyond initial displacement, counselors absolutely have to adopt a trauma-informed perspective. This means looking way beyond just diagnosing a list of symptoms to truly understand their historical context. We aren't just asking, what's wrong with this person? Instead, we're asking, what has this person survived? When refugees present with anxiety or depression, a trauma-informed lens ensures we're understanding those feelings within the context of severe, ongoing adversity. That brings us to part three, rethinking trauma and resilience. Now, a strictly pathological view might look at behaviors like hypervigilance, intense fear, or emotional numbness and label them as highly dysfunctional. But a multicultural perspective completely reframes this. It views those exact same behaviors as totally reasonable adaptive responses to extraordinary situations. Think about a refugee who always insists on sitting facing the door at a crowded coffee shop. That isn't necessarily paranoia or a severe pathology. It's a brilliant survival mechanism, honed over years of real persecution. If you're constantly under threat, staying hyper-alert to danger is exactly what keeps you alive. We really have to avoid pathologizing survival. And because refugees have so often experienced deep betrayal by governments, military forces, or institutions, counselors can't just expect immediate emotional disclosure. Step one is always building psychological safety and trust, and that has to happen gradually through deep empathy, consistency, and respect. Crucially, step two is waiting for client readiness. If you push someone to immediately dive into traumatic memories before they feel completely secure, you actually risk re-traumatizing them. Only when they're truly ready can we move to step three, the deeper therapeutic exploration of that trauma. The pacing always has to be dictated by the client's sense of safety, not some arbitrary clinical timeline. This naturally flows into our next core concept, which is cultural humility. Refugees often come from cultural systems with vastly different beliefs about mental illness, family structure, or spirituality. If we impose our own cultural assumptions, we can actually, unknowingly, recreate the very marginalization they're trying to heal from. Now, practicing cultural humility doesn't mean you need to be an absolute expert on every culture on Earth. It's an ongoing orientation. It's about approaching the client with genuine curiosity, recognizing the limits of your own cultural knowledge, and actively respecting their differing worldview. But while acknowledging trauma is vital, we have to make sure we aren't exclusively focusing on deficits. Surviving war and displacement requires an unbelievable amount of strength that counselors should actively empower. We're talking about deep persistence, courage, adaptability, and determination. A modern approach helps construct narratives that include not just the victimization, but this incredible capacity for survival and growth.
All right, let's shift gears to part 4, disability and the social model.
Let's apply this lens to our second population today, people with disabilities. Historically, the medical model placed the problem entirely inside the individual. It viewed a disability as an individual defect requiring treatment or correction. But the modern multicultural approach, the social model, recognizes the massive impact of societal barriers. It completely flips the script, stating that difficulties arise not just from physical impairments, but from environmental obstacles, inaccessible structures, and discriminatory attitudes. To really cement this in your memory, think about this scenario. Imagine navigating your day in a wheelchair and arriving at a doctor's office, where the only entrance is a flight of stairs. The distress in that moment doesn't come from the wheelchair, right? It comes from an environment built without you in mind. Whether it's an inaccessible building, a lack of communication, accommodations, or a discriminatory attitude, that is often the true source of distress. The psychological distress actually reflects societal exclusion. The environment is what is truly disabling. Let's unpack this further in part 5, stigma, autonomy, and accessibility. There's this incredibly powerful quote from the source material that really hits the nail on the head. Discrimination and exclusion generate greater distress than the disability itself. This highlights the devastating psychological consequences of societal stigma, which so often stereotypes disabled individuals as dependent, weak, or incompetent. This constant daily stigma can lead to internalized shame, low self-esteem, and severely diminished opportunities for personal growth. Counselors have to directly address these psychological consequences. Because of this, effective counseling has to move way past just helping someone adjust to a disability. Instead, counselors have to help clients actively challenge those negative societal messages. Since disabled individuals often experience excessive control from institutions or caregivers where basic decisions are just made for them, therapy really needs to return power to the individual. It's all about fostering autonomy, promoting self-advocacy, and developing personal agency. And fundamentally, we have to demand total physical and communicative accessibility as a baseline standard of competent practice. Simply put, if a service isn't accessible, it is directly contributing to inequality. And finally, part 6, context over pathology. Let's synthesize everything we've covered to really lock this in. When we put these two populations side by side, the parallels are pretty striking. Yes, their specific counseling focus differs, navigating displacement and trauma for refugees versus demanding accessibility and fighting stigma for individuals with disabilities. But look at this. Their overarching challenges are identical. Both face discrimination, social exclusion, and huge institutional barriers. And most importantly, their shared needs are exactly the same: empowerment, a focus on inherent strengths, advocacy, and cultural sensitivity. Both of these groups perfectly illustrate our core lesson for today. Psychological well-being simply cannot be understood without closely examining the broader social environment that a person lives in. So I'm going to leave you with this provocative thought to chew on. Are our counseling models designed to fix the person or understand their world? When we actively remove barriers, challenge injustice, and promote genuine social inclusion, we aren't just treating symptoms anymore. We're actually changing lives. Keep that question in mind as you continue exploring these concepts, and thank you so much for joining me for this explainer today.